Welcome to this episode of Thrive With Us. Today we're going to be talking about neuropsychology and neuropsychiatry with a focus on the older adult population. I'm lucky to be joined by two wonderful guests, Dr. Ash, consultant psychiatrist and medical director at Thrive, as well as Christi Gadd, licensed clinical psychologist. Welcome, Ash and Christi.
Thank you, Sarah, for having us here.
I just mentioned that the topic of today's conversation is going to be neuropsychology and neuropsychiatry. And I think a lot of people that are watching this episode probably have no idea what that means, just that it sounds maybe very clinical, possibly a little bit daunting. So why don't we clarify what it is that we're here to talk about?
Okay, so let's kind of go back into what actually neuropsychiatry means. In a very simplistic way, I would probably say it's at the crossroad of neurology and psychiatry. And interestingly, way back, they were used to be one single branch. But over time, as we've seen, that psychiatry moved across mind and behavior, neurology moved across brain pathology and physical deficit. But what we've started to recognize is that they are nothing but part of the same pathology. And it's really important that they have a deeper connection. And that deeper connection is what we are bringing to the clinical practice. And that's what neuropsychiatry is all about. So the simplistic explanation would be when there is a pathology in the brain, we are asking ourselves what is not just wrong with the brain, but how do you also explain the issues around emotions, issues around behaviors. So we always look at our patient in one single label. They are not two separate entity, and that's what neuropsychiatry is all about.
Okay, so it sounds like it's a holistic approach and it's merging a couple of different fields and approaches. So Christi, when it comes to neuropsychology as well as neuropsychiatry, what are some of the conditions or challenges that people present with?
Yeah, so similar to what Ash described, neuropsychology would be the interface between neurology and psychology. And as Ash pointed out as well, we used to think that those are two separate things, that your brain and your body is two separate things. And more we are seeing. So the stereotypical description of neuropsychology would be it's about the relationship between your brain and your behavior. We've already expanded that to say that human beings are a lot more than their brains and their behaviors. So it's about the interaction between your brain, your immune system, your behavior, your emotions, and how do all of these things fit together. So on the one hand, it can be neurological conditions, and how does that affect your behavior? I fell off my horse, I bumped my head, I got a really serious concussion, and now I'm having all of these symptoms afterwards. What's up with that? That's the one aspect where we see something happened in the brain and now your behavior is affected. But it's also the other way around when we look at our behavior. Using substances, screen time, and what we do there and how that affects our brain, decision making, how do we plan our daily lives in a way that enhances our brain. So one of my favorite little sneak caveats here is that a lot of the psychological research shows that talk therapy and coming for a therapeutic process actually makes structural changes in your brain. So to me, it's about not one or the other and not looking at the one or the other. So some of the conditions I've worked with would be the degenerative conditions, dementias, Alzheimer's disease, motor neuron disease, multiple sclerosis, Parkinson's, strokes, brain tumors, traumatic brain injuries, falling off bikes, falling off horses, all those kind of things. Ash, help, what am I missing? There's so much.
I think that's quite an extensive list, but there are a few others that I've actually seen in my own practice. Genetic disorders, they actually fall under the remit of neuropsychiatry. Then we have personality changes, again, under the remit of neuropsychiatry. And maybe I can just throw an example here. I do recall seeing a young adult, about 20-year-old, who presented suddenly to ER with change in personality and behavior. Because of lack of integrated care between neurology and psychiatry, that got picked up as drug-induced psychosis. There was absolutely no Remeton treatment. We got through a scan done. It turned out to be he had a frontal lobe tumor, which was surgically resected. His behaviors reverted to the baseline. So again, it's really important that we have to consider our patients as not as label, but as single entity. And I think it's really important for us to have that integrated care between neurology and psychiatry. I think you've highlighted all the neurodegenerative conditions. The other one is epilepsy. Again, a very underreported neuropsychiatric condition. We talk about epilepsies. We don't talk about the brain disorders, basically the mood disorder, which is highly related to epilepsy, increased incidences of suicide, schizophrenia, and psychosis. No one really talks about it, but epilepsy is kind of a very, very highly underreported condition. ADHD is also actually considered as a neuropsychiatric condition now because of not just about the brain changes, but also the behaviors and that impulsive traits that we talk about. That's also part of neuropsychiatry. And I think it's just a very small series of things that we are talking about. Lately, basically just after COVID, we've been seeing an upstick of what we describe as the autoimmune psychosis, which has been seen more commonly in younger population who actually present as if they have a psychotic episode. Following a brain scan and a CSF testing, they turn out to be encephalitis, which is secondary to an autoimmune condition, which is not actually treated with psychotropic medication, but by immunotherapy. That is a classic neuropsychiatry case.
Okay. So what I'm hearing from both of you is that it is really this connection between the mind and the body, and that the relationship is bidirectional. So both of you kind of reference that the mind can impact on the body and the behavior, and also vice versa. And we've moved away to having more of a fragmented, separate approach into something more holistic, and that is much more in service of the client or the patient. And Ash, you very importantly said that we want to move beyond seeing them as just that diagnostic label and seeing them as a whole person and treating them accordingly. So both of you mentioned a number of different conditions that kind of fall within the scope. Why don't we talk about some of the ones that are kind of more common? So I think dementia and Alzheimer's, maybe you can walk us through what those look like, and then maybe what the treatment approach can be from both a psychiatric and psychological, psychotherapeutic lens.
Okay. So dementia as such, or Alzheimer's, they're just one part of the neurocognitive condition. So we have absolutely, I think there's not a specific numbers to the neurodegenerative disorders, but dementia is actually one of them. So we have the Alzheimer's, which is the most common associated dementia, but we have frontotemporal dementia, we have dementia of Lewy body, we have Parkinson's dementia. So there are absolutely multitude of dementias. But the key element that we understand with dementia is nothing but a slow, progressive decline, not just in cognition, memory, and behaviors. And because it's such a slow decline, sometimes it becomes very difficult for us to identify, are we actually looking at dementia? Are we actually looking at a mild cognitive decline? And that can only be differentiated with the collateral as well as a longitudinal history. So that makes it much more important for us to continue with these assessments. We cannot diagnose someone with dementia with one single assessment. There are multiple assessments, which is also added with a lot of neuropsychological testing as well as brain scans. Combination of these three things together will actually help us decide if this is one, dementia, and if it is dementia, then what form of dementia it is. Because every dementia has a very different subset of behavioral disorders. And what actually works for Alzheimer's does not really work for Parkinson's, or does not work for Lewy body, does not work for frontotemporal dementia. So there's no one single medication that fits all of them. So it's very important for us to be very clear what path we are actually going ahead with and what diagnosis we are confirming here. So when we talk about neuropsychological testing, we actually talk about cognitive assessments. So that is the EDOS, or we have the Addenbrooke cognitive testing that we used to do in the UK. We do scans, so we could be a CT, MRI to structural or a PET scan, because some of the dementias are not actually diagnosed on a CT or MRI. We actually have to go for PET or functional scans. Then these are the most important testings that we do, and collateral information from the family. And then we conclude the diagnosis.
Yeah, if I can add to that, from my perspective, the one part that I always think, should I get the collateral information? I think I've got a clear picture. Collateral information to me is the swing vote. So for me, when it comes down to investigating concerns around dementia, is my mom... Is this memory decline? Is this personality change? What's going on there? To me, I think the two big variables is looking at the pattern. What kind of difficulties are we seeing? And looking at the collateral information in addition to what the client is reporting is really, really important. Because when we look at a person who is currently moving to a later age stage, there are so many variables that play a role. And what often gets misdiagnosed is we often get scenarios where a mood condition presents as memory decline, or memory difficulties or cognitive difficulties look like a mood condition or anxiety in that population. So it's really important to take your time and really extrapolate those carefully, because there's so much going on from a life stage perspective. There's loss, there's grief, there is the sense that I'm aging, and then it starts getting very difficult to untangle what is going on. Even just the fear of cognitive decline creates anxiety, which starts looking like cognitive decline.
Absolutely. And that's why we always say aging is just not a physical decline, but it's a massive biological and emotional transformation. And a lot of individuals actually struggle with that transformation.
Yes.
Just imagine someone who's been highly productive person and coming on the other side and actually losing that productivity is a massive, massive decline for them. That's why it's very important to have those frequent assessments and never be, and one shouldn't rush to give them a diagnosis of dementia, because just the word dementia itself has transformative issues, not just on the client, but also on the family, because
It's
families
hefty.
also struggle to even get to understand what this actually looks like.
No, that makes a lot of sense. And so what I'm hearing from you, and as we discussed earlier, is this idea that we don't want to reduce people to labels, but at the same time, doing a really, really thorough assessment to identify exactly what it is that we need to treat and to support is very critical. And it's important to disentangle between some things that might be age-related and are kind of more like developmentally normative, as well as things that might be a little bit less so, and that we should be gathering information from a range of sources, the patient, him or herself, as well as people that spend a lot of time and are able to offer different vantage points, so that you can really tailor the treatment, whether it's with medication or with any kind of therapeutic intervention. So let's think about, or maybe share with our audience, how this kind of shows up in clinic. So we're talking about technically what it is you do when someone is presenting, but who are these people that are coming? Are you finding that a lot of people are coming, on their own because they're noticing that there's a shift? Maybe their long-term partner is bringing them in, an adult child. And I'm asking specifically about the older adult population, but what do people come with?
Sarah, again, I think we probably might have, it's different here compared to the UK.
Yes.
And I can only draw from my experience from the Western country. Because of the awareness that individuals, families have about dementia, I actually see clients on their own actually presenting themselves. being concerned about the cognitive decline,
Yes.
being concerned about mood issues, behavioral changes, comments made by the loved ones that something's not right with them. Now reverse the situation to the one in UAE. I think there's a lot of cultural stigma and misappropriation. So they find it much easier to normalize that this is absolutely part of elderly or aging process. There's no need for us to go and see a doctor for this.
Yeah.
And that's why it actually remains highly underreported here. And by the time we actually get to see them, they're actually at the later stage of dementia, which makes it much more difficult to treat them.
So what I'm hearing from you, given your experiences both in the UK as well as in the UAE, is that the context is quite different. And in the UK, there's maybe a little bit more awareness about what are some of the symptoms or some of the things that you might need to be concerned about. And because in part there's more awareness, there's a little less stigma or hesitation for people to reach out, and people are presenting themselves. Whereas here, people don't quite know. And I think probably part of the reason for that is the population here is quite different.
Yes.
The distribution is quite different. The proportion or percentage of elderly people in the UAE is very small compared to other places.
It's absolutely very small. But I think it was important for us to highlight that difference.
Yes.
Otherwise, in a routine neurocognitive clinic, that's what we used to call them, or a neuropsychiatry or a cognitive clinic. So once the client walks in, so either it's a direct referral, that is the client presents himself, or we actually get a referral from different physician. Like they might have seen a psychiatrist, and psychiatrist might have felt, okay, this does not look like a mood disorder. There's something more to this.
Yes.
Or you could potentially have a referral coming from the GP because of the concerns that are raised by the extended family.
Yes.
So once they actually present to our clinic, the idea is to gather as much as information, but at the same time making sure you're not taxing the client. If someone is actually presenting with cognitive decline, I think it's really important to give them that time, be very patient with them, and try and then get all that collateral information from the family. And the key areas that we actually look at is the progressive or a gradual decline. Again, I'll give you an example here. So someone with Alzheimer's will have what we describe as a very slow progressive decline. Someone with a vascular dementia will what we describe as a step ladder approach.
Okay.
They'll be doing absolutely okay, and then sudden dip, and then back, and then a dip, but they were never back to their baseline.
Okay.
If you have someone with frontal lobe dementia, a lot of aggressive behavior, change of personality. If they were very aggressive initially, they become very apathetic. A lot of sexualized behavior, a lot of promiscuous behavior, which creates not just an issue for the family, but extended community. Then we have Parkinson's, where they would probably have a history of Parkinson's, which is nothing but people who present with issues around tremors, shakes, issues around walking, gait, and they start presenting with cognitive decline. Then we have something called as a Lewy body dementia, which comes with a lot of visual hallucinations, kind of seeing things when they are not around, along with behavioral and gait disturbance. And there are a lot of others which I'm not going to go into, but these are the ranges of the ones that we see in the clinic. Once the assessment is completed, where you kind of start making a provisional diagnosis in your head that this is what it appears to be, but we never share with the family initially.
Yes.
We always make them clear that the assessment is still ongoing. Get them to some radiological investigation, then refer to my neuropsychologist for further cognitive assessment, which takes its own sweet time. Then we generally, in a neuropsychiatry department, there's a lot of emphasis on the MDT. So once the medical assessment is completed, radiological assessment is completed, neuropsychological assessment is completed, then we all meet together to kind of share our findings. And once we've concluded, this is what we are looking at, we bring the family back in, explain to them, this is what we think, and this is what has happened, and this is the diagnosis.
Okay.
And in that sense, what I would love to add there is that to link back to what you were saying, Sarah, about labeling a person and stigmatization. In this sense, what I found is that getting an accurate diagnosis is actually so meaningful to help the person and the family that it if you really get to an accurate picture, it just helps bring down the animosity and the frustration in the family, because it gives you the opportunity for empathy. If we think of, for example, a person presenting with frontal lobe dementia, there's a lot of very difficult behaviors going on that creates conflict in the family. And if the family is going, what's up with this person? The family members will sit with a sense of hurt, betrayal, what's going on here? And because it looks like personality change, it'll be what's wrong with this person. Where if we go through the proper process and we don't just take it as, oh well, this guy, don't want to be in relationship with this guy anymore, and you can really go and do the proper analysis and see there's actually something going on here that explains this. Then we can come in and make some decisions around safety, care. There's medication that can assist with the impulse control. If it is an Alzheimer's memory picture, then we can start coming in with mechanisms to support. I mentioned my sister in the previous podcast as well. I rely a lot on her knowledge. She's a speech therapist. So she taught me that looking at something like audiometry and getting their ears tested and making sure that their glasses are up to date. If we strengthen the sensory input and we make sure that they can hear accurately and they can see accurately and they are engaged in society, linking back to the research on grandparents and their relationships with their grandparents. This one is for all the parents out there. Use your grandparents to help you look after your children, because it actually helps maintain the cognitive functions for as long as possible.
And I'll probably add to that is having an advanced planning in place.
Yes.
The issue managing neurocognitive condition is very much reactive, which does not really help. So it's really important to be very much proactive when we are having this advanced planning. And that's the reason I always advise the family to start working on that advanced care planning. So that we are exactly aware if this is a situation that's going to play out, these are some of the things that we can actually do in order to help not just the client, but also the family. Because what I've noticed over the years, managing or caring for someone with dementia is not easy.
No.
A compassion fatigue comes in. And when that starts coming in, it comes with a lot of internalized guilt. And it's very difficult to shift that internalized guilt. So it kind of ends up, we are not just treating the client with dementia, but sometimes a majority of these cohort, they actually get diagnosed with adjustment disorders, depression, anxiety. So always make clear in that file, start on the advanced care planning straight away, which could potentially include not just home support, but maybe respite care or maybe long-term nursing care based on the degree or level of the cognitive decline.
So what I'm hearing from you, kind of rewinding a little bit in our discussion, is that here in this context, a lot of the referrals might not be self-referrals, but they might be from other practitioners who are noticing something, and people come, and it's very important to gather that thorough information to figure out what it is, and then with that multidisciplinary approach, treat it accordingly. And Christi, you were saying that it's really important in a lot of ways because it provides that sense of explanation. And I can imagine if you are in a close relationship with someone and all of a sudden you don't recognize them, that's really tough. And if it's a change in the personality rather than maybe a memory decline or something that you might be able to anticipate, it's easy to slip into what is wrong with him or her and then react to that. But you can have more empathy if you're able to recognize that this is happening for a reason that is outside of their control. And then the empathy piece connects with what you were just sharing, Ash, and I think it's really important, is this sense that, people, especially as adults, age and their needs increase, their physical needs and their cognition and other things start to decline, they rely on close others, at least as a first sort of layer of care. And in a lot of cultures, that expectation is really there to step in and to provide all of that support, which is a wonderful and a beautiful thing in a lot of ways, but there is still a heaviness that's there. And that heaviness can bring with it some guilt. And so we kind of circle back to this idea of care needs to be really holistic, not just for the patient at hand, but for their entire support circle, because they're being impacted directly and indirectly.
Absolutely. Absolutely.
Yeah. And if we think of our expat population that we work with in Dubai, then we can imagine the heartbreak and the guilt of having a parent in your country of origin who's struggling with this, and you are sitting on the other side of the world. And then we might have an imbalance where the bulk of the day-to-day care is coming down on one sibling, and the expat sibling is maybe a little further away, sitting with a sense of guilt, helplessness. What do I do when my family is so far away and I'm seeing my parent age and struggle and experience things that are beyond what we expect from aging.
And there's the other aspect of we being part of the sandwich generation, not just looking after our elderly parents, but our growing kids. So there's the compounded guilt.
Yes.
If we are not looking after kids and being there, what happens to our kids? If you're looking after kids, not being there, what happens there? And the other aspect is that culture plays a very big role. So if someone's coming from a Middle Eastern culture, Far Asian culture or Indian culture, the concept or the idea of sending your elderly parent to a care home is absolutely unheard of. Because
Shameful.
it's a very shameful act. And not just shameful because of you sending them there, but also being shameful from the community perspective. And it sometimes becomes very difficult for us to, as an expat, all of us, explain to the wider community there is a reason why we're doing for what we are doing, not just because we're trying to get rid of it. But it's very difficult to get this across to them. And I think that further compounds as if they're not being useful to their parent. And that is something we always have to keep in mind when we are interacting with this cultural group of people. I think we just sometimes we just let go of that, thinking, everything's fine, they'll take care of whatever is happening. I think it's never really that way.
And to me, that links back to the advanced care plan that you were talking about.
Absolutely.
I'm sorry to my family, they're all being brought into this podcast now. With my own mom back in South Africa, we have had clear discussions around what are the plans? At what point does what happen? When does she move closer to us? Well, I'm not there anymore. When does she move back to closer to my sister so that there is more support? When do we start making decisions around safety to drive? When do we start making decisions around safety to live alone and needing care and things like that? And to me, being far away, that brings a big sense of peace, that we've had these discussions in advance and we know what the plans are and we know where it's going.
I think it's a good example, and because you've done that, so maybe I can also do that. So my dad had a stroke about 6 years ago. He's managed really well. He's absolutely back to his normalcy. We started having these conversations as soon as the stroke happened. I was, if I remember, I was in Ethiopia traveling, and Dad had a stroke, so I had to fly back down to India. We started the advanced care planning from the point of his stroke, which included basically getting him to stop driving, which he absolutely agreed to do that. Getting him on regular reviews with the neuroradiologist so that we proceeded ahead with stent surgery, which has really worked for him. We've been seeing some signs of cognitive decline, which is what we will expect him. He's 76 now, but he's still managing all his activities of daily living. But one of the plans that we are 3 siblings, so one of the plans we have is that every frequent few weeks or few months, one of us will travel into India, so that we are making sure that everything's been taken care of. Nothing has been left to guesses. Everything is done on common sense basis. So we are all being very much proactive. We are making sure that his needs are met as a priority, but also making sure that mom is looked after properly. So we don't forget that other person, because that is where the caregiver burdens come in.
Absolutely.
And I think that is something we all should be very much aware of. Again, that's something that we don't talk about. See, in some of the conversations that when we have with our clients, we will always probably ask the caregiver, how is your dad doing? How is your mom doing? But we never ask our caregivers, how are you coping?
Yes.
Yeah, and I think this is a really important point, and we've talked a bit about the socio-cultural component, and what you were just sharing now reminds me of what happens as well with new parents, right? When a woman is expecting, it's how are you feeling? How are you doing? How is baby developing? And as soon as the baby comes into the world, no one cares about the, receptacle, basically, is what you become reduced to, and check in. And it's really important because they need to have those resources to be able to provide that care. And you were saying, Ash, about this whole sandwich concept, and you referenced that there's aging parents as well as growing children. There's also us.
Yes.
We the caregiver. We are actually the caregiver, if you look at that.
I know, absolutely. But we're so in that caregiver role that sometimes we forget that, for women, it can be a period of perimenopause.
Correct.
For women and men, there can be like the, career trajectory and all of these other things. And I'm sure there's very male specific things that I'm missing as a woman.
Help, Ash.
Yeah, seriously. Sorry, everyone.
The midlife crisis, as we talked about.
There you go. The midlife crisis. So there's like the self, and then there's the care for the older parents and for the younger children. And it's a lot. And then when you compound that with coming from this society where you're referencing all these collectivistic societies where the nucleus is the family, it's not the self. So if I or you or anyone from those kinds of societies sends their parents off, it's like you're sending them off somewhere far away. You don't care about them.
Yes.
And you're a bad child, And so there's so many, I think, social and emotional layers that intersect with the culture and the development that we kind of need to think about.
And we should also highlight the financial implications of all
very
this.
True.
We should not forget that.
Very true. Yeah.
And it's not just that easy or simplistic to say, okay, it's easy, just send them to a nursing home. But who funds that nursing home?
Yeah. And it's easy to just bring a carer at home,
But who funds that?
Exactly. So we have spent some time talking about the changes that might happen for an older adult, given that we're filming this from the UAE, where we have kind of more younger adults and middle adults. Why don't we talk a little bit about the social and emotional implications of, watching your parents and other close people age? Christi, have you noticed anything?
The word that comes up for me is ambiguous loss.
Okay.
And there, one of my favorite recommendations is for people to watch Grey's Anatomy.
Okay.
Because one of the most beautiful depictions of ambiguous loss is watching Meredith Grey go through the process of seeing her mother with Alzheimer's dementia deteriorate in front of her eyes, and then sitting with the anxiety of, is this going to happen to me as well? And in later seasons, her daughter developing anxiety around, how does this play out? What happens if my mom presents with this? So in that sense, on a personal level, I think there's a lot of anxiety for yourself around, is this going to happen to me too? And then the ambiguous loss. The person is there, but piece by piece, they're disappearing. It's almost like a tree losing its leaves a little bit. And that is really devastating.
Absolutely. It's like a very slow, progressive decline to the point of death.
Yeah. And that's painful to see, because it usually comes in glimmers where the emotions are still there and their experience is still there, but the cognition might be going and their sense of awareness. Yeah, I remember my own grandmother towards the end of her time on earth. She was quite confused and disorientated. But when she saw one of us, her eyes just lit up and she took you by the face. And I think there, it's holding on to those beautiful moments, but also giving yourself the time and space to grieve for what it is that you are losing. It really is a hard thing to go through.
I think you're bringing up something really, really important, and that is this idea that a lot of people associate grief with loss and loss of life. And what I'm hearing from you, and I would imagine you agree with this, Ash, is that you can grieve the loss of the person that you knew. You can grieve the loss of the relationship that you had. You shift from this person is my parent, assuming that they played a very active role in raising you. They looked after me. They were my caregiver. Okay, fine. We've had to have a bit of a shift in our dynamic. And slowly, I'm seeing them slip away. So there's a grief there. And then also it's like, well, is this going to happen to me? So there is some anxiety there. And then if you also have children, then I would imagine there's also some fear that are they going to be sitting where I'm sitting right now and experiencing this too? So it sounds like a lot of layers of grief and loss.
Absolutely. And not just the anxiety, there's also that hypervigilance behavior that comes in. And when we talk about the loss in dementia, we also talk about not just the loss of a person, but we talk about the loss of dreams.
Yes.
The house, the roads, the memories, just about everything. And, you know, the saddest part is that you actually looking after a parent, but the parent does not even recognize you anymore. Which is where we've been talking about the ambiguous loss. And I think that is something we also feel as medical specialty, because we do not actually capture that essence of loss. We are so focused on the idea, okay, there's this individual who's kind of going through that. Let's just kind of focus on that person, not actually focusing on the caregiver.
And then we're assuming that it was a relatively comfortable parental relationship with no unfinished business. But we all know that that's very rare. So now you also sit with some of your own childhood wounds, and a lot of the symptoms that we are seeing come up probably hit on those childhood wounds.
Of course.
So again, declaring my own bias towards the benefit of psychotherapy is healing from that and working through your own wounds and prioritizing your own growth and your own self-care, filling your own cup as the caregiver from afar or nearby, and clearing up things in your relationships. So individual therapy, couples therapy, family therapy, go to therapy with your sibling if things are difficult there to help clear things up. And I have had quite a few families scattered across the globe concerned about a parent and needing to make very difficult decisions, and having someone guide and facilitate that process who has an understanding of the neurocognitive condition, but also has an understanding of a family system, of grief, of emotional experience to assist and guide that process, can take the load and the burden off just a little bit.
But sadly, there's a very small cohort which actually does this.
Yes.
So the awareness is not there. And I think we are so consumed looking after the parent that we actually forget to tend to our own needs,
Yeah.
whether it's emotional, physical, biological needs.
Financial also.
Financial,
Right? It can also
absolutely.
be my resources. I've exhausted all of them.
Absolutely.
My time and, what's going to give. It's you. And then that just compounds the problem. I think one of the things that both of you sort of referenced in different ways is the sibling, right? So Ash, you were saying that you're one of three and you kind of have the system and it sounds like it's working well. I'm sure there's hiccups as there is for any plan.
Absolutely.
Of course.
But I would imagine also what happens in these kinds of situations more generally is that there is a replication of the family dynamic. It's like one of the siblings is going to be the responsible one that needs to call the shots, make the decisions. They're the ones that kind of, don't get a lot of acknowledgement or praise. And then there's someone else or maybe a couple of others who aren't really expected to carry their load. But when they do anything, it's like, oh my God, wow, you're the best. So I can imagine as well, like resentment, irritation, frustration, discord creeping into that sibling relationship. And that being really difficult to navigate because as you're watching your parent or parents slip away, your siblings, if you have them, are the only link that you have to your childhood.
Correct.
So that is also another form of potential loss.
Absolutely. And it's very difficult to quantify that loss.
Yeah.
And I think, so in my case, coming back to family, so I'm the one who calls all the shot. Well, it's a good thing or a bad thing because I'm the doctor. But the other two siblings, I have made it very clear to them, anything that has to do with their care needs is something that they have to take care of, which basically includes making sure that they attend to their hospital appointments, they attend to their physician appointments, the physiotherapist is coming up. But I'm kind of calling the shots, being here, making sure everything's been taken care of. But luckily, maybe because the field I am in, so I emotionally and psychologically, I know how to navigate these through, but not everyone can actually do that. And you're quite right. There's a lot of resentment that actually starts creeping in. And as we always say, not all the siblings are the same. So one might be actually financially much more better off compared to the others. So there's always that discord when it comes to money, the discord that comes to how do we share these, the discord about who's going to take that last or the final call, who's going to pull that plug from the ventilator. So those are very difficult ones. But I think it's really important for families to have these conversations from the beginning rather than at the end. Because at the end, it's a chaos. Nothing works for anyone.
The emotions are too high.
Absolutely.
Have the discussions early while the emotions are low.
And there's always a space to revisit and revise things. Nothing is set in stone.
Absolutely. So in the UK, what happens is, once a decision is made, that this specific individual may not be able to sustain at home, the conversation starts happening with social workers because a bigger component of the treatment package or treatment planning is a social worker. Because in the UK, it's a social worker who makes that decision on the placement. So that's a social worker who starts having those conversations with the family about placements in a nursing home / rehab, the finances involved in that placement, the downsizing of the house, selling of the property, sharing of the assets. So that, again, is not an easy conversation to have because you are navigating through different family members. But we always bring them in as soon as possible so that we're already making that plan in our head that this is going to happen. Everything is kind of written down on a piece of paper with a copy sent across to all the members of the family.
And there, I'm just hearing so much loss for the patient and the family. Imagine it's the house you've been living in forever. It's the house you grew up in. It's your childhood home. It's all of those boxes with all of the pictures full of stuff that your parents just kept out of sentimental value. It's a deeply emotional process to go through.
So I think I've learned a lot from the two of you over the course of this conversation, and some of the key takeaways for me are, as with many things, most things, all things, physical and mental health related, earlier is better.
Yes.
That comes for presenting to, a professional to see what's going on. Is it developmentally normative? Might there be something else? I heard from the two of you that this holistic approach is really important, not just from like a medical or psychological perspective, but also in terms of engaging all of the different stakeholders. I also heard from the two of you that we really need to kind of know that different people are coming in with different things. So we've got the main patient or client, and we need to tend to their needs, but also their caregivers, as well as the stuff that they bring historically, the stuff that they're going through in the present, as well as the things that they're going to have to navigate in the future, are all things that we need to take into consideration. It's really tough. It sounds like it's really tough for everyone, but there are things that we can do to sort of alleviate that with the advanced planning, with leaning on other people, whether it's other professionals or other people in our social circle. So thank you both so much for your insights and for your time today.
Thanks, Sarah, for having us here.
Pleasure. Thank you.